The emergency delivery. We're going to be talking about the stages of labor, what normal deliveries look like, and then we're going to talk about some complications, including cord prolapse, shoulder dystocia, and breech presentation. So there were about 3.7 million births in the US in 2019. And though not in the same year, but just to get an idea, there were around, in 2012, around 1.36% of deliveries were out of the hospital. Why might some deliveries happen outside of the hospital? It might be inadequate or non-existent prenatal care, transportation difficulties, remote settings, disaster situations, premature labor. And that's why EMS units, transporting laboring patients, facilities preparing for disaster situations, and EDs should have sterile delivery kits to be ready when this happens. And then I also wanted to share with you that according to a report from the CDC, apparently non-induced vaginal deliveries occur mostly in the early morning, so be extra prepared in the early morning. So why am I talking about out of hospital deliveries? Natural disasters such as wildfires, hurricanes, floods can be unpredictable and devastating, and we might find ourselves practicing under some of situations like this at some point. Dr. Dukas shared with me an article related to Katrina in preparation for the hurricane at Keesler Medical Center. The OBGYN department was sheltering 36 pregnant women. And in the middle of the storm, one of them decided around 39 weeks gestation, decided to rupture their membranes and have regular contractions. And as we see in that picture up there, they ended up having to turn an ICU bed into a makeshift operating room because the power generator during the storm had been cut off. So we might never find ourselves in such an extreme situation, but we will certainly find ourselves at some point in situations where we might not have, where we might have limited resources and find ourselves having to be the ones to help a laboring patient. Okay, so now let's review a few terms to describe labor. First of all, rupture of membranes, it's a gush of clear or blood tinged fluid. It can also be greenish brown if there's meconium. Premature rupture of membranes occurs in about 8% of third trimester patients. This may require the need of antibiotics or steroids, but this isn't kind of part of the scope of this presentation. In addition to that, we're going to talk about dilatation. Fully dilated is 10 centimeters, about the size of a melon. And we basically look for measure it using our index finger and middle finger and basically sweep around the cervix. Then we have effacement, which we see in this lower picture, where we basically, the cervix starts to thin. And finally, we have station. We talk about station with regards to the pubic symphysis. It basically is a way to describe where the fetus is within the pelvis. The pubic symphysis is zero station. Anything more proximal is described as negative. Anything more distal is described as positive. And then something else we want to look out for is false labor or Braxton Hicks contractions, which are irregular contractions, which happen mostly in the lower abdomen and don't lead to cervical changes. Then the stages of labor. So first stage of labor basically is from when we start having contractions to the point where there's full dilatation. That part is divided into the latent phase, which is when you start having irregular contractions. The thinning of the cervix occurs, and there's and the cervix softens. Sorry. Then you have the active phase, which is from 3 to 4 centimeters until fully dilated. And then the second stage of labor is from being fully dilated to delivery of the baby. and then third stage delivery of the baby to delivery of the placenta. So this part is going to kind of just be a general outline or suggested outline, because it's going to vary a lot depending on the situation where you find yourself and also how far along the laboring patient is. So in terms of examining the patient, first you're going to obtain maternal vital signs, fetal heart rate, get IV access, and then you're going to start off with some questions such as, are there contractions? Has there been rupture of membranes? Is there any bleeding? What's gestational age? And with regards to gestational age, if the patient isn't quite sure, there's a couple of things you can do to help determine this. One of them is Najeel's rule, which basically you take the last menstrual period, you subtract 3 months, and then add 7 days to that to get an estimate. You can also use ultrasound when available. And then something else, you can use fundal height, but that's more limited. One, because with obesity being so common, it's difficult to tell. And then also in labor, as the baby descends down the pelvis, it's not as useful to look at the fundal height. In addition to this, if the mother's in active labor, you're gonna evaluate the perineum, look for bulging and crowning. If this is not the case, then you can do more of an examination. And then you're going to examine for frequency of contractions. You can use nitrazine to determine if there's been rupture of membranes, dilatation, effacement. And then something else you're going to look at is presentation. You can do this with palpation, but you can also do it using the ultrasound again, if available. And then you're always going to be checking for hemodynamic stability of the fetus and the mother. Something that you are going to look for is that if you suspect that there's any issues with the fetus, you are going to place the mother on the left lateral position. You're going to start IV fluids. You're going to start oxygen. Signs of issues with the fetus include bradycardia, tachycardia, and late decelerations. Late decelerations isn't something that you can tell with Doppler, so you're basically going to be guiding yourself with bradycardia and tachycardia. And normal fetal heart rate is between 120 and 160 beats per minute. And then the other thing is that whenever possible, try to use clean the perineum, drape the mother, and then use sterile gloves, gown, mask, okay? See. Oh, one more thing about the previous slide, sorry, was that if there is bleeding, you're going to want to be careful with digital exam. So if it's whenever possible, check with the ultrasound first, because you're going to want to make sure that if they're check for placenta previa, okay? And that's the picture on the right. So now what does a normal delivery look like? First, as we can see in this picture, you're going to support the perineum with a sterile towel. And then with your other hand, you're going to support the head. And as the head moves out, you're going to then check for a nuchal cord by palpating around the neck. A nuchal cord actually occurs in about 35% of cephalad presenting deliveries. If the cord is loose, you're going to reduce it around the head and proceed with delivery. If the cord is tight, you're going to, in the most easily available area, you're going to clamp the cord in 2 places and cut in between, and then continue with the delivery. And then, so once the head is out, you're supporting the head on both sides. You're going to place gentle traction downward to deliver the anterior shoulder. And then you're going to then use upward traction to deliver the posterior shoulder. Once the baby is out, you're going to use a towel, stimulate the baby. If everything has gone all right, you're going to place it on the mother. And then their next step is going to be to clamp the cord. Whenever possible, you're going to allow between 1 to 3 minutes before clamping the cord. because this helps improve iron stores in the newborn. You're going to do this by placing one clamp about 8 to 10 centimeters distal from the newborn, and then the second clamp about 3 centimeters from that, closer towards the mother, and then cut. The EMS procedures say that, for example, if there aren't clamps available, you can tie off in the same locations with gauze, but don't cut, just tie off. And then finally, the next step, once the baby's delivered, is delivering the placenta. The placenta delivers between 10 and 30 minutes after the child. And what you're going to do is, with the clamp, you're going to place it close to the vagina and use gentle traction. You're going to want to be careful because you are going to want to avoid any issues with tearing the cord, also inversion of the uterus, or any disruption of the placenta itself, because all of these will lead to bleeding in the mother. And then finally, once the placenta's out, you're going to apply pressure at the fundus to promote uterine contraction, and then you follow that with oxytocin to sustain uterine contraction if you have oxytocin available. Okay, so now talking about some complications. First of all, we're going to talk about cord prolapse. It occurs in somewhere between 1 and 6 per every 1,000 deliveries. The EMS manual, for example, says that if you are examining the patient and you feel a pulsating cord, what you're going to do is just leave the hand in there, because the hand, you're going to use it to push and relieve any pressure on the cord until you are able to get the patient to a place where they can have a C-section, because that's what's indicated in this case. One thing that they also mention is to not try to reduce the cord. Just leave it where it is. One of the places I read said to actually try to wrap the cord with something sterile and moist. Other options, as we can see in the picture on the right, is that if there's might be more of a longer time to get the patient to the hospital, for example, you can try filling the bladder with saline, to use that to provide the pressure, as opposed to having the provider be there with the hand the whole time. Something else is that you can use the knee to chest position, like we see in the C picture. Trendelenburg can also be used. And then kind of the other suggestion is different ways to prop up the pelvis, basically. In this, basically, we see 2 general themes. One is basically pushing up, and the other one is for allowing gravity to pull down. There is some, theoretically, there can be arguments made that allowing gravity to pull can be better because it can prevent further prolapse. And then the other thing is that depending on pushing, how effective it is will vary depending on the station of the infant or the fetus, because the higher the station, the harder it'll be to actually reach and provide adequate pushing upward. And as you can imagine, all of these are suggestions that are based on small case series, because there's no way to actually do randomized trials on any of these. Then we're going to talk about shoulder dystocia. It happens in about 0.6 to 3% of vaginal deliveries in vertex presentation. It basically is impaction of the anterior shoulder on the pelvis right after the head delivers. You're going to see what's called the turtle sign, because the head is coming out with pushing, but then it kind of retracts a little bit. Some issues with this are shoulder, brachial plexus injuries, clavicle fractures, fetal hypoxia, and then you can get also postpartum hemorrhage and perineal lacerations. And this brings me to a controversial topic, which is episiotomies. They're not recommended during normal vaginal deliveries because of the risk of 3rd and 4th degree lacerations. But in this case, they may be necessary to expedite delivery of the infant. If you do find yourself needing to do one, you are going to use lidocaine in the perineal area, and then you're going to protect the fetal head, and with scissors, you're going to make a 2 to 3 centimeter cut, either at 45 degree angles, as you can see in the picture, or in the midline. And this will allow for a more expedited delivery. And then once we've done this, then we're going to talk about a couple of maneuvers that we can try. Let's see if I can get this. So up here, we see McRoberts maneuver. This basically is opening the knees open wide and brought up towards the abdomen as much as possible. And then the provider is going to provide suprapubic pressure. It's important that it's suprapubic and not at the fundus to help push the baby downward and hopefully get the shoulder out. This works in about 50% of the time. As we can see down here, another technique is basically delivering the posterior arm. You're going to use the fingers to basically flex the elbow and sweep out the arm. And then another option, another option is the Rubin maneuver that we see over here. Basically, for the Rubin maneuver, what you're going to do is you're going to use the hand, you're going to place it in the posterior aspect of the posterior shoulder and basically push towards the fetal face. And then we have the opposite maneuver, which is the Woods corkscrew maneuver. You place the hand on the anterior aspect of the posterior shoulder and then push towards the back of the fetus. And then finally, we have the Gaskin maneuver over here. And that basically the mother is on all fours and you're placing downward traction to deliver the infant. This apparently is about 80% successful about 80% of the time. But as you can imagine, it can be quite difficult. One, if the patient is plugged into monitors and things like that with the movement, and then also fatigue is another issue with trying this. And then finally, we're going to talk about breech presentation. It occurs in about 3 to 4% of term pregnancies and 25 to 30% of preterm infants. The risk is for cord prolapse, trauma, hypoxia, and fetal distress. C-section is indicated because of concern for entrapment of the head, since the fetal parts, the presenting fetal parts are smaller and they don't dilate the cervix appropriately. One exception to this is in the Frank position, since basically the buttocks actually can dilate the cervix as well as the head, and it can allow for delivery to actually happen. In a case like this, what we're going to find is that you're going to allow for the infant to deliver up to the umbilicus without any traction. And then at that point, the legs might either deliver on their own, or if they don't deliver on their own, it might require flexion and abduction of the thighs. And at that point, you're going to hold on to the pelvis in the sacrum area and keep it at no more than 45 degrees to the horizontal, and with an oblique angle allow for delivery of the arms. And then at that point, then you go back to a horizontal position, and you're going to maintain flexion of the cervical flexion by using one hand in the occiput and shoulders, and then the other hand holding the maxilla, as we can see in the bottom picture here. Okay, and then one dilemma with regards to this type of delivery is basically the speed with which it happens. Some argue that faster is better because you are worried with acidosis because of cord compression after the delivery of the umbilicus. The other side is doing it slower to try to prevent trauma. there is zero evidence in favor of either of these. Sorry, I did it again. Okay, so finally, don't be scared. Most deliveries occur without difficulties. Be prepared but be flexible because conditions will just vary widely depending on the case. And then deliveries can be very stressful because we don't do them very often. And also you have two patients, the infant and the mother, that you have to take care of. But periodic review is basically the best thing you can do to try to prevent this or be ready for this. And then finally, don't drop the baby. Yeah, it's really funny actually. I started out to prepare for this looking at Tintinelli's, and my fiance comes up behind me and looks at the book and he's like, they have to tell you to not drop the baby? Yeah. So, and that's it, just references.